Hello, everyone, and welcome back to Just Medicine. I'm Gina, and today we're continuing our exploration of the intersection of medical assistance in dying and mental health in this two-part series. In our previous episode, we delved into the complexities with Dr. Diane McIntosh, discussing the disproportionate impact that MAiD might have on vulnerable populations. We talked about the barriers to access as a driver for seeking MAiD and covered some of the health equity issues. Today, we have another distinguished guest joining us, Dr. Derryck Smith. Dr. Smith will share valuable insights into this multifaceted topic, and he brings a unique perspective to our ongoing conversation. Dr. Smith is a psychiatrist, a clinical professor emeritus at UBC, and a former board member of Dying with Dignity Canada. Join us as we delve deeper into MAiD for individuals facing mental health challenges. Enjoy the episode.
You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello, everyone, and welcome to Just Medicine. My name is Gina, and today we have Dr. Derryck Smith with us. Dr. Smith is a psychiatrist in Vancouver, BC. He was the past president of the British Columbia Medical Association, and he is an active supporter of MAiD for Mental Health. Dr. Smith, welcome. It's wonderful to have you join us.
It's great to be here. Thanks.
So before we delve into our conversation, I want to give you a chance to introduce yourself. Can you tell us a bit about who you are, your background and training, and how you became involved in the field of psychiatry?
Yeah, I did. When I was in high school, my best friend developed schizophrenia, which was a total mystery to me and his other friends at the time. So I became interested in mental illness based on personal experience. And after doing a Bachelor of Science at Waterloo, I entered medical school with the specific purpose of becoming a psychiatrist. So it's been a long-term plan to be involved in the psychiatry. So I finished my medical school in London, Ontario. I worked in the Caribbean for a few years, and then I came back to Vancouver, where I was fortunate to be accepted into the residency program and finished in 1985 and been practicing psychiatry since then.
Wow, it seems like your interest started way, way back, and it stems from lots of years ago. And it seems like you've had a fascinating career path, which hearing all of this makes me even more excited to jump into our conversation today. So with that being said, why don't we get started? To begin, can you share your thoughts on the legalization of MAiD for sole mental health conditions and sort of the reasons that led you to advocate for this cause?
I became interested in MAiD when I was on the board of the Canadian Medical Association. And the case that was before the courts at that time was a woman named Sue Rodriguez, who had ALS. After a long deliberation, the Supreme Court of Canada decided by a very narrow margin, 5-4, to deny her access to assisted death because they weren't sure what Canadians felt about assisted dying. At that point, it was very controversial, and the Medical Association was opposed to assisted dying. And after talking to Ms. Rodriguez myself, I decided that this was a just and appropriate option that Canadians who had were dying in a terrible fashion should have access to. So I was very involved from the beginning. After my father died quite a horrible death, and he asked me to help him commit suicide, and I could not do that because that was illegal. But I told him that I would assist in changing the law. And fortunately, I had an opportunity to become a psychiatric expert witness in the Kay Carter case, which was before the courts in 2012. The Supreme Court eventually decided in 2015 by a decision of 9-0 to grant Kay Carter an assisted death. Now, this was a bit of a moot point because Kay had already had an assisted death in Switzerland well before the court case went before the judges in British Columbia. the Supreme Court was emphatic in their judgment. Not only was it 9-0, but they also all signed the final judgment, which is a very unusual situation. The chief of the Supreme Court at the time, Beverly McLaughlin, who was also from Vancouver, felt very strongly about this. She had written the minority opinion on the Rodriguez case. So what happened after the Supreme Court decision came down was that individuals who wanted to have assisted death had to apply to the court for permission to do so, because there was no legislation in place at that time. And in the spring of 2016, I had an opportunity to assess a woman who's known as EF from Calgary. EF applied to have an assisted death based just on a single diagnosis of a psychiatric disorder. She had a very complicated conversion disorder. She'd been sick for about 30 years. Although doctors said there was no reason why she couldn't open her eyes, she hadn't opened her eyes for the last 10 years. She'd had all manner of treatment. She'd been hospitalized on many occasions, medication, psychotherapy, and she had simply had enough of this suffering. So she applied for MAiD, and the court in Alberta, the Court of Queen's Bench, granted her an assisted death based just on a psychiatric diagnosis, using the rules that came out of the Carter case. EF eventually came to Vancouver, where she had an assisted death. So what this illustrated was that if we were just using the rules that came out of the courts on Carter, that people with psychiatric illness had a legitimate charter right to an assisted death. Now, what happened with the legislation was that when the Liberals introduced the first legislation on MAiD, C-14, in June of 2016, they added a clause to the legislation that was not in the Carter decision. And that clause was, your natural death must be reasonably foreseeable. And that sounds simple enough, but what that did was it basically denied assisted death to people with disabilities and people with mental illness, because their deaths were not going to be eminently foreseeable given the nature of their illness. So the Liberal government took away a charter right from people with psychiatric illness. So the whole movement since then has been not to expand MAiD to include people with psychiatric illness, but to restore the rights, the charter rights of people with psychiatric illness to have an assisted death.
Wow, thank you so much for sharing that. And also the personal stories are very valuable to hear. And it seems like there's been a significant evolution in the MAiD legislation, starting just from when it was for physical conditions and when only death was foreseeable, to now where they've added the new clause. And you mentioned restoring the Charter of Human Rights. I think that's absolutely true, because psychiatric illnesses are medical disorders just as much as any other medical condition, and they deserve equal consideration whenever we are approaching or considering new healthcare legislations. And it's very valuable to kind of hear that you are validating the intensity of the suffering that is experienced by people with psychiatric conditions. Another
two cases I should talk about. The first one was in 2018, and it was a case of a woman known by AB in Ontario. AB applied to the courts for an assisted death because she had been denied. She was suffering from osteoarthritis. She was in her late 60s, and the court decided, after listening to her, that she was eligible for assisted death, even though osteoarthritis is not usually a disease that people die from. And what the court said was, it's not so much about the diagnosis, it's about looking at the entire person and how the illness is affecting their quality of life, their suffering, and so on. So what the courts directed us to do was to look at the entire person, not just the isolated psychiatric, or not just the isolated medical diagnoses that went along with it. Now, the next case was a man, Jean Touchon, in Quebec in 2019. Mr. Touchon was suffering from a disease in which he was progressively losing ability to move his body. At one time, he'd been able to move his left arm, but at the time of the case, he was totally confined to a wheelchair and couldn't move. This case was an extensively covered case, both from the medical and psychiatric community, and there was a lot of psychiatric testimony offered in this case, even though Mr. Truchon did not have a psychiatric diagnosis. And the judge in Quebec ruled that the clause in C14, natural death must be reasonably foreseeable, offended the charter and had to be removed. So she struck down the C14 and instructed the government to revise the legislation. So at that point, the Liberal government came in with Bill C7. Now, many of us who had worked on this were assuming that they would simply get rid of that clause, natural death must be reasonably foreseeable. But the way they got around that was to have two classes of patients, those whose death was reasonably foreseeable and those whose death were not. And that's where we are today. We have a track 1 and track 2 patients. Now, the Liberal government also banned assisted dying for psychiatric patients when they introduced that legislation. And it was only by working through the Canadian Senate that an amendment was inserted into Bill C7 to restore rights to psychiatric patients for MAiD. When the bill finally did pass in the House, the implementation of MAiD for psychiatric illness was delayed for 2 years. It was supposed to come into effect in March of 2023. And then because of what I would call big P politics, in other words, the Conservative Party of Canada became very involved with this and was opposed to this, it was delayed again until March of 2024. Even now, the Conservative Party is still fighting against this. A private member's bill in October was narrowly defeated, and it remains, in my mind, uncertain as to whether psychiatric patients are going to finally have their charter rights restored for assisted death in March of this year.
Do you think that by March 2024, it could be postponed once more?
I think it could easily be postponed. And I'll tell you that if the Conservative government was elected and formed the next government, they would probably try to get rid of it altogether. So there's no doubt that people feel very strongly about this. About half the psychiatrists in Canada are opposed for MAiD for psychiatric illness. The other thing that's important to note is that the only reason we have any MAiD legislation in Canada at all has nothing to do with politicians. The politicians have shown no leadership on this issue at all. It is only by court decision that we have any MAiD legislation. So the politicians, I think, are only reluctantly reactive to court decisions. We have MAiD in Canada because of informed opinion and direction from judges, nothing to do with the politicians.
Earlier on, you mentioned a little bit about the two different tracks with MAiD. I was wondering if you could tell us a little bit about how the decision-making process for a patient that's applying for MAiD for sole mental health condition and how that differs from a patient that's applying for MAiD with a physical condition.
Well, we don't have any experience with MAiD for psychiatric illness yet, other than the case of EF, which I previously mentioned. So it's a bit theoretical, but what is being proposed, and it's different in each province, is a series of safeguards to ensure that people are appropriately assessed prior to getting MAiD for psychiatric illness. So it's probably going to involve an assessment by a psychiatrist, which again is unique for psychiatric illness because there's no other conditions that you need a specialist to assess you for. I mean, if you have a cancer or heart disease or lung disease, you don't need to have a cancer, lung, or heart specialist assessing you. But the thinking has been that because this is so controversial, that it's going to be necessary to have one of the assessors being a psychiatrist for people who are applying for psychiatric illness as the only diagnosis.
Thank you for bringing that up. And I think
having at least one assessor that is an expert in the patient's condition, that can be very pivotal in terms of alleviating some of the concerns that people have surrounding MAiD for mental health. And I believe that by having that expert opinion, then it can really help ensure that the decision-making process is really individualized for that patient specifically in their unique circumstance.
Yeah, you may be right. I mean, I was initially opposed to this. And the reason for that is you've mentioned this already. What is different about psychiatry? Why is psychiatric illness kind of hived off as something special? Psychiatric illness is a medical diagnosis. It's a disorder of the human brain. And the last time I looked, the human brain was part of the body. I'm opposed to anything that segregates out mental illness as being something different. To my way of thinking, this is evidence of a lasting stigma that's been associated with mental illness. People may not realize that 100 years ago, the average Canadian thought that mental illness was the work of the devil. And we've come some distance from that, but still we have the stigma. And this separation of mental illness away from the rest of medicine in this legislation is, to my way of thinking, another example of the lingering stigma associated with mental illness.
Absolutely. And you mentioned stigma, and that kind of leads me to the next question I wanted to ask you. So mental health disorders, a lot of times, as we know, is not readily visible to others. And unfortunately, as you said, the stigma still remains to this day, both in the medical field and in the public. And so given this, I wonder if, from your personal experience or personal encounter with patients, if you felt as though they feel or worry that their requests for MAiD is maybe not going to be taken as seriously as someone with a physical health condition.
Well, I think the people who are doing the assessing, and these are primarily family doctors and nurse practitioners, are well attuned to the issues of psychiatric illness. I don't think there's a problem getting psychiatric patients assessed and approved. The only obstacle, not at the doctor end, not at the assessor end, but has only been the legislation. So if this legislation gets passed and implemented, that there are not going to be particular obstacles for psychiatric patients. Already, there's a Canadian association that was formed by Canadian doctors, CAMPA, which is consists of the people who are involved with providing and assessing for MAiD. They already have established training modules for doctors across Canada who want to get involved with assessing and providing MAiD for people with psychiatric illness. So the Canadian doctors are well prepared to take up this challenge. All we're waiting for is the political process to operationalize MAiD for psychiatric illness in March of this year.
Hearing that there are training modules being implemented, that is definitely very reassuring, and that the patients who are applying for MAiD with sole mental health conditions will receive a sort of standardized care. And like you mentioned, the assessors may not have the stigma, but I think still in public and maybe other professionals in the healthcare field, there might be a little bit of a worry that patients feel as though, because of the invisibility of their disorder, that their suffering is not given the attention or consideration that it deserves. And unfortunately, to this day, physical pain is treated sometimes with more empathy than mental health conditions, and that can lead to the severity or unbearableness of these psychiatric conditions being underestimated.
Absolutely.
You did talk a little bit about your experience with court cases. I'm wondering if you've had any personal experience in your practice with MAiD.
Yes, I've done a limited number of assessments. I am trained to provide MAiD, but I've never done it. And I'm unlikely to. I'm now 77 years old, so I'm not going to take up a new practice in medicine. But I have assessed a number of patients who have had MAiD. There have been a couple of cases prior to C7 in which people with psychiatric illness have received MAiD. I've been involved with 2 cases where people with anorexia nervosa qualified for MAiD, and that was based on the fact that it was the opinion of the assessors that their natural death was reasonably foreseeable because they were refusing further treatment. They had already been through the gauntlet over many, many years, and they were actively refusing to go back into hospital. They were actively starving themselves to death. And that seemed to me to be a cruel and unusual way to for a person to end their life. So I had opined on 2 occasions that those individuals were eligible for MAiD with the single diagnosis of a psychiatric diagnosis because their natural death was reasonably foreseeable.
It's very informative to hear in a unique circumstance where it is a psychiatric condition, but as you mentioned, their death was foreseeable. And for me, this is very valuable because I haven't had much clinical exposure to MAiD yet. And also, I'm sure for our listeners, hearing you talk about your experience with the law in action and how it's impacted patients, it adds a really valuable layer to this conversation, and I really appreciate that. Now, shifting our focus, I wanted to talk a little bit about the people who have so far sought out for MAiD. So according to the Canadian government in 2022, which I believe is the latest report that has been released, there were approximately 13,000 MAiD provisions, and that accounted for around 4.1% of all the deaths in Canada. And this was excluding mental health conditions. The top reason was cancer in this case. And the current statistics suggest that the majority of the individuals who have opted for MAiD since 2016, when it first became legal, up until 2022, were individuals who belonged to high or middle socioeconomic status. They were well educated and they led fairly autonomous lives. So I'm interested to hear if, following the changes that we expect to see in March 2024, if you anticipate that there will be a shift in the demographic of people who are seeking MAiD.
No, I don't think so. People who represent the disabled, not the disabled themselves, but their professional associations have been very concerned that the disabled are going to be victimized by this and somehow put to death in order to save money or because they're causing a grief for their families or their communities. The opposite, as you pointed out, is the case, and that is that, if anything, the disabled, the disadvantaged, marginalized communities, and so on, are grossly underrepresented in people who are assessing MAiD currently. That's going to continue on, I believe, because the people who are opting for MAiD are well-informed, well-educated. They usually have a good support network. They usually have a family doctor, all of which means that if they want to consider MAiD for one of the options for ending the misery and suffering that they're having, that MAiD is readily available for them. And these statistics are also this in Canada, the same as in the Benelux countries, which have been doing this for more than 20 years. It is not disadvantaged communities. It is well-educated, upper middle class people who are seeing MAiD as an option to end their suffering. The other argument that has been put to death, and that was the issue raised by the palliative care community, and that is that MAiD somehow is going to disadvantage people who are seeking palliative care. This has been tested in court on a number of occasions, and the justices who have looked at this have consistently concluded that there is nothing incompatible with MAiD versus palliative care. And that report that you quoted, about 80% of Canadians who had MAiD had access to palliative care. Now, the issue with palliative care is that nobody gets out of palliative care alive. The end point of palliative care is death. And many people who are in palliative care, and I have had friends go this route, realize that after a while, they have had enough suffering. They do not want to linger on for a few or 4 more weeks being treated with morphine in hospitals, with intravenous's. They want to end their lives now at a time and place of their choosing. And that is why I think we're seeing a large number of people who have been in palliative care are in the end opting to have assisted death.
Do you worry at all that people who have more structural vulnerabilities, who are from those more marginalized communities, who have lack of social support or financial struggles, that they may be more disproportionately affected by this new legislation?
No, I don't. I think that just the opposite. The same thing applies to for MAiD for psychiatric illness as applies to the other medical diagnoses. These people are underrepresented. They are the people who are unlikely to have MAiD the people who are well educated, well informed, and have good social supports are the ones who are probably going to be able to take advantage of MAiD. So as I say, if anything, you could say that the socially disadvantaged are at risk of not having appropriate access to MAiD.
You mentioned several times that people who are more disadvantaged may be more underrepresented with MAiD, and I'm wondering, do you know why that is, or do you have any ideas why that may be the case?
Well, I think they may be misinformed. They may not know that MAiD is an option. They may not have a family doctor. You have to keep in mind that the Canadian healthcare system is in a crisis and has been for the last 10 years. A million people in British Columbia do not have a family doctor. If you do not have a family doctor, it's very difficult to assess any kind of specialist care. So if you don't have a family doctor, who do you go to talk about MAiD? You may not have a medical professional who you even know or can even access on a regular basis. So that's one of the problems with that we're facing now and into the future with Canadian healthcare is the collapse of the system, the inability to provide appropriate services to keep up with the aging of the population and the growth of the population as well.
Absolutely. And I appreciate you bringing up the fact that access to care is definitely an issue in our healthcare system, and especially in British Columbia, but nationwide as well. Now, adding a little bit to the complexity of this issue, I do want to mention that from my understanding, and please correct me if I'm wrong, but there currently are no safeguards in place that require patients to fully exhaust all treatment options before considering MAiD. So individuals in Canada, in theory, can pursue MAiD without having explored or having had access to the available treatments. And considering the potential consequences of this, there is a concern that legalizing MAiD for mental health might redirect our focus from providing this care and resources toward dying. And I'm curious to hear your thoughts on that.
Yes, well, if you go back to the original Carter case, the ruling was that people had the ability to refuse services which they did not find acceptable. And that's true for any condition. Like people are not forced to have medical treatment in Canada. You can choose to have it or not to have it. For example, if we looked at the mental illness, if when MAiD is available for people with mental illness, if you have major depression, you will not have to have had electroconvulsive therapy as one of the prerequisites. One of the built-in informal safeguards in the whole system, however, is the training and professionalism of Canadian doctors. You have to keep in mind that MAiD legislation is not a piece of healthcare. It's not part of healthcare at all. It's an amendment to the criminal code. So if Canadian doctors are found to have provided MAiD inappropriately for a Canadian, they could be charged with murder. This is a very high threshold. So Canadian doctors have reacted appropriately. There has never been a Canadian doctor charged, and certainly not convicted, of any offenses for inappropriately providing MAiD. So I think we can continue to rely on the professionalism of Canadian doctors and of psychiatrists to ensure that people who access MAiD fully meet all of the criteria. Now, the typical person with a psychiatric illness who is approved for MAiD is going to be very much like the patient I described, EF, in Alberta. It's likely to be someone at least in their 50s who has had psychiatric illness for 20, 30 years, who has had multiple treatments, who has had inpatient treatment, psychotherapy, many kinds of medication trials. In other words, they have exhausted all of the available resources, and in spite of that, they still have their illness and are still suffering. That's the type of patient. It is not, there have been some sensationalized press stories. An 18-year-old woman shows up at the emergency room at Vancouver General Hospital, and there's a request for MAiD. Well, this is totally inappropriate. That person would never be approved for MAiD under the current legislation. This is going to be an option for people who are middle-aged, who've had refractory psychiatric illness for many, many years. And we can count on Canadian doctors to ensure that those safeguards are kept in place. But this brings us to one of the points of major controversy in the field of psychiatry. One of the criteria for MAiD is that the illness that you have must be, quote, irremediable. And about a third of Canadian psychiatrists believe that psychiatric illness is never irremediable. Now, I don't know what kind of patients they've been working with, but I have over the course of my practice have seen a small number of patients who, in spite of all of the treatments that are available, continue to have psychiatric illness and continue to suffer. So what we're talking about here in terms of numbers, I would estimate that there may be about 50 Canadians a year eligible for MAiD for psychiatric illness. So it's a small number of people. They're going to be chronically ill. They will have had to have shown that they've had an extensive number of treatments, not all treatments, not every last treatment available. They're the people who are likely to benefit from this legislation. The psychiatrists who are opposed say, well, there's always something, we can't predict what's going to happen with psychiatric illness. There may be some brand new cure comes up. There may be ketamine or psilocybin or something that's going to cure these people. Well, that's possible, but we have to put ourselves not in the shoes of the psychiatrists, but in the lives of the patients. This is really a patient-driven initiative. It really has very little to do with doctors as far as I can see. Doctors are only the instruments that allow patients to access a charter right. So it's about what patients want, not what doctors think patients should have.
I think that's a very important point, and you bring up patient-centered care and the idea that, after all, the overarching goal here is that we are providing empowerment to individuals who are suffering immensely. And something that you mentioned that I think it's really important to highlight is that the majority of the patients who will be seeking MAiD for sole mental health conditions are not individuals who have been suffering with depression, say, for only a few months. These are individuals who have been undergoing suffering for a really long, extended period of time, which undoubtedly will elicit frustrations and make sense why they would consider MAiD. You mentioned one of the eligibility criteria being irremediability, and you said that you have encountered patients, at least a small subset, that throughout your career have been irremediable. I wonder how you think we can accurately assess these patients, and is there a sort of common consensus on how to identify these patients?
Well, as I've said, they will have been under treatment for years and years. They will have demonstrated a commitment to getting better. They will have tried medication, psychotherapy, hospitalizations. What we have learned from the extensive experience in the Benelux countries is that, similar to the patient AB, it's not about diagnosis. If you look at, there's an excellent paper published on the first 100 patients who received MAiD for psychiatric illness in Belgium. The diagnoses are all over the map. I was surprised to see that there were patients who have received MAiD for personality disorder, schizophrenia, depression, conversion disorder. So the issue is not the diagnosis, it's how the diagnosis is affecting the person. We all know that certain conditions are difficult to fully treat. Schizophrenia is a perfect example. There are numbers of people who have schizophrenia who never recover from their illness in spite of the best care. Personality disorders are similarly difficult conditions to treat, and we all have encountered, treatment-resistant depression. This is so well known that we even have multiple definitions of what constitutes treatment-resistant depression. So if a person has treatment-resistant depression and they've had it for 20 years, why would they not be eligible for MAiD? I cannot understand people's opposition to that if they have a psychiatric illness where there's been an honest attempt to treat this, a commitment on both the psychiatrist and the patient to improve their functioning, and still they are suffering. You referenced a report from 2022. If you look at that, the major reason why people access MAiD, and these are people primarily with cancer, heart disease, lung disease, it was not that they were suffering with pain. It was that their quality of life had diminished to the point where they no longer had any joy in their life. So if that's why people with so-called medical illnesses are accessing MAiD, why would we not look at that same criteria for people with psychiatric illness? When your life has ceased to be meaningful to you, you've had all kinds of treatment, you are still suffering immensely, you have no hope of getting better, that's the sort of person who's going to be eligible for MAiD once the new legislation hopefully comes into effect in the March of 2024.
Absolutely. And psychiatric conditions significantly can reduce a patient's quality of life. We know they affect relationships and a person's overall well-being. So that's absolutely important. And thank you for sort of going through how irremediability is defined in terms of psychiatric conditions, because I think sometimes it can be unclear. And I know there's a lot of disagreements surrounding that area. But like you said, living with treatment-resistant disorders can be extremely debilitating, and they can significantly reduce one's day-to-day functioning. So having the choice to pursue something like MAiD can really restore the human right to decide whether or not we want to continue living on in such circumstances.
One of the other great advantages of MAiD is that it empowers people to have control over their final days of their life. In other words, the time of their death, the place of their death, and who's going to be present. This was the very argument that Sue Rodriguez made many years ago, but it's equally a potent argument today, because the average person with these chronic medical conditions ends up dying, but they frequently end up dying in a hospital in the middle of the night, not surrounded by anybody. They may be in a room by themselves. A person who decides to have death by MAiD can pick the time and place. They can choose which family members they want to have there, which friends they want to have present. It's a timed and controlled environment in which the person has a peaceful death, and maybe even more importantly, the family and friends are there to wish them the best and wish them on their way. That's so much different than the way many people with chronic illnesses die, and it's certainly a better option for psychiatric patients than to go out behind the barn with a shotgun and kill yourself. That's the only option that psychiatric patients have now. So MAiD is much different than suicide. It's a planned and thoughtful process. It involves discussions with your family, with your physicians, with other people in your community. And that's the other argument, that is that this MAiD is not condoning suicide. It's the exact opposite of that. It's allowing people to have a dignified and meaningful death in an environment of their choosing at a time of their choosing.
That's a very important point that you raised, the idea that an individual can regain that control over the way they die and have that balance between autonomy and being able to die in a peaceful yet dignified manner. But you mentioned MAiD being a very well planned out process of dying, contrary to suicide. But a lot of times we know that suicide can be well planned out as well. What do you have to say about that?
Well, usually suicide is not discussed with your doctors. It's usually not discussed with your families. It frequently is unsuccessful because people are using methods that are not going to kill them, but are going to just maim them. So I remain of the view suicide is a part of psychiatric illness. MAiD is not. MAiD is a thoughtful, carefully planned, logical, approved process for people to end their suffering. And that's considerably different from suicide. And we've had extensive experience talking to the families of people who have had family members die by suicide versus family members who have died by MAiD. And the outcome for the families is extraordinarily different. As a humorous aside, MAiD also, if you're Irish, you can be present at your own wake. So you can be at your own party, your own celebration of life. It doesn't have to take place after you're dead. It could take place while you're alive. And at the end of that process, you know that you're going to have a compassionate and caring doctor allow you to slowly slip into the pathway to death, again, at a place and time of your choosing. Most people who opt for MAiD choose to die in their home. No one I know chooses to die in an ICU at 3 a.m. in the morning. And that's the option that many patients are facing these days. So that's why we're bringing a human face to suffering. We're allowing people control over their own lives. Why do we want people to suffer needlessly at the end of their lives? It seems maybe a trite comparison, but we do not allow our pets to suffer. We do not allow our pets to go on forever and ever. The vast majority of Canadians and the people who even raise animals as a living, farmers and cattle rangers and so on, do not let their animals die like that. They provide euthanasia for their animals. So if we care that much about relieving suffering in our pets and animals, why would we not offer that same option to humans? That strikes me as being so counterproductive. I think the reason why opposition to MAiD has been so strong that largely comes from the religious community, and particularly opposed is the Roman Catholic Church, which believes that it is only up to God to that can allow you to have death. So if you're a Catholic, I respect their views. Catholics can choose to die and suffer as much as they want, but they should not be able to impose that view on the rest of us who may want to look at other options.
With what you said, it reminds me that MAiD isn't mandatory. And so this is just an option that's reserved for people who truly need it and want to seek it. And so if there is someone who is against MAiD, they don't have to pursue it. You also spoke a little bit about families, and I think that's really important to touch on because sometimes they're not incorporated in these conversations as much, but they are significantly impacted. And like you said, the experience that families may have through MAiD is completely different than they would with suicide. And I think that's something that's really important to note. The importance of us really humanizing the suffering that the patients are experiencing. Now, as we're approaching the end of our episode, one of the final questions I wanted to ask you is, how do you think healthcare providers can ensure that decisions around MAiD for mental health are made with a lens of equity, considering that patients can come from a diverse set of backgrounds and circumstances?
Well, patients have to, first of all, present themselves as wanting MAiD. This is not something that doctors should ever suggest to patients. It comes from the patient. And if the patient does not even know that MAiD is an option, then they're not going to request it. So part of the way of dealing with disadvantaged communities is to let them know that this is a health service that is readily available if they want to. Once the patient comes to the conclusion that they think they've had enough suffering and they want to consider MAiD, then they have to go through a process of assessment. Now, if your family doctor is opposed to MAiD, and some doctors are, and that's legitimate, the family doctor must provide an effective referral to another doctor, meaning that they have to refer the patient to a doctor who would consider MAiD. Then the patient needs to have a discussion with their doctor. They need to have an assessment. In the bigger centers, these can be done. These are organized through the health authorities. Vancouver Coastal, for example, has an excellent MAiD process where they provide a lot of administrative backup. In smaller communities, that kind of administrative backup may not be available, which again disadvantages people from a small isolated community. So I think a program of education is appropriate so Canadians know that this is now an option. Once patients know this is an option, that gives them the ability to have that initial discussion with their healthcare provider.
Thank you for kind of going through the steps of how a patient can seek out for MAiD, and education is extremely important, and hopefully more underrepresented groups can get access to that information regarding what MAiD is, how they can pursue it, and also the idea that it is an aspect of care that they can seek out. This has been a very complex landscape, and so I really appreciate this discussion and your perspective on how patients and healthcare providers can navigate these discussions with sensitivity. But we have reached the end of our discussion, so I'm curious, do you have any final thoughts or advice?
A couple of difficult situations that doctors have to navigate, and in most people who are requesting MAiD, their families are very supportive. There's a small number of patients, however, whose families are opposed to MAiD. They may be opposed for a wide variety of reasons. So there have been cases in the in British Columbia where the family has raised a complaint where their loved one has been assessed for MAiD and has received MAiD, and these have been adjudicated by the college and the courts, and it has been held that MAiD is not about what families want; it's about what the individual wants. So clinicians should always meet with the families, listen carefully to what the families have to say. But in the end, it's not a decision for the family, it's a decision for the individual patient. The same as if if a patient was looking at surgery, it's not the family who gets to consent to the surgery, it's the patient themselves. If the patient doesn't want surgery, they don't get it. If they do, they will probably go ahead. But so families should be consulted, but the family does not have the final say as to whether a person can request MAiD or is eligible for MAiD or even has access to assisted dying.
That's a very important point. I think it's, like you said, similar to any other aspect of care that you're providing. It's important to talk to the family and include them in the conversation, but ultimately, as a healthcare provider, your duty is to the patient. But that brings us to the end of our episode. Thank you so much for all the reflective notes that you've touched on. I want to thank you, Dr. Smith, for coming on to our podcast and speaking on this very pressing and important topic. Our conversation has provided me personally with a lot of valuable takeaways, and I'm sure has also helped our listeners form a more comprehensive view of MAiD for mental health. So it's been a pleasure exploring this topic with you, and thank you so much.
Good. Well, thanks for having me, Zena. And I want to compliment you on having the enthusiasm to put podcasts together. I think they're an excellent way of providing education and are a great forum for a discussion on a wide variety of topics. So thanks for inviting me, and it's been my pleasure to speak with you.
Absolutely. And also thank you to everyone who was listening in. Stay tuned for more episodes of Just Medicine in the near future.